Good morning, and a special good morning for those of you who may be joining us from the West Coast. Thank you for joining the Association of American Medical Colleges and the AAMC Center for Health Justice for this very important briefing entitled Data for Health Equity, the Foundation for Creating Healthier Communities. My name is Karen Fisher, and I'm the Chief Public Policy Officer of the AAMC. And as many of you may already know, the AAMC represents all 155 US accredited medical schools, as well as over 400 major teaching hospitals and health systems, and 70 plus faculty and academic societies. Our members are deeply committed to working both within their institutions and with their communities to addressing health justice issues. In case we had any latecomers who may be coming on just now, I think it's a good time for me to say this session is being recorded, and we will provide the recording and the slides to all registered participants after it is over. That said, if there are any press here, this briefing is off the record. And if you want any quotes or want to follow up, please reach out to the speakers directly. I'm very delighted to be joined today by our very impressive list of speakers who are going to highlight how all sectors of our health ecosystem, including housing, public health, medicine, transportation, all have similar health equity data needs related to demographics, individual level social needs, and community level social determinants, among others. To kick things off, I am very pleased to share opening remarks by Representative Judy Chu, who represents the 27th District of California. Congresswoman Chu is a member of the Ways and Means Committee, the House Ways and Means Committee, and importantly is chair of the Congressional Asian Pacific American Caucus, also known as CAPAC. Congresswoman Chu was not able to be with us in person today, but was very gracious to record the following video for us.
Hello, I'm Congresswoman Judy Chu, and as the chair of the Congressional Asian Pacific American Caucus, or what we call CAPAC, I want to thank you all for joining today's briefing on data for health equity and how we can use that to create healthier communities. This is especially important for communities of color who have suffered the most from this pandemic over the past 18 months. That is why I'm so pleased that AAMC put together today's briefing, especially in light of the lessons of the past year. The COVID-19 pandemic showed us that we still have glaring health disparities in our country, but it also highlighted how we lack the needed data to help explain or understand what to do about those health disparities. In fact, we still lack data on groups like Native Hawaiians and Pacific Islanders, even though throughout the pandemic, these groups had significantly higher infection and mortality rates than any other racial group in more than a dozen states across the country. And it's similar for members of the Black, Latino, and Native American communities who are more likely to be hospitalized with severe cases. These disproportionate infection, mortality, and hospitalization rates are the result of long-standing and well-documented health disparities, such as a lack of access to healthcare, food insecurity, housing instability, and economic inequality. Yet throughout the pandemic, I was shocked by the lack of high-quality data we had on COVID-19 cases broke down by race. To this day, CDC data on the race of individuals who were infected with COVID-19 is still unavailable for more than 30% of cases. This is most alarming because race is just the tip of the iceberg. We also lack almost any large-scale data on other key demographic factors such as ethnicity, income level, occupation, and other social determinants of health. This lack of data continues to hinder our understanding of the impact of the pandemic on historically marginalized communities, such as the AAPI community, and it makes it harder to know where to direct resources to help and rebuild. That is why, as we look towards the future, it is critical that we learn from the lessons of the past and take steps to address the long-standing health disparities that fueled the disproportionate impact of COVID-19 on communities of color. That starts with high-quality data. Without high-quality data, problems are often missed and solutions harder to find because we lack the information we need. For example, During the pandemic, smaller data sets from local public health jurisdictions gave us reason to believe that the Native Hawaiian Pacific Islander community was being disproportionately impacted by the virus. However, official CDC data for the longest time did not include disaggregated data on this community. At the beginning of the pandemic, CDC included all AEPIs, including Native Hawaiian Pacific Islanders, in the other category. Because of this practice, the issues facing this community were obscured and they were often left out of the discussion on disparities. However, we in CAPAC continued to push for the release of this data and worked with stakeholders to better track state-level data. And because of those efforts, we were able to more effectively advocate for the inclusion of the Native Hawaiian Pacific Islander community in the COVID-19 response. Similarly, greater access to data on all social determinants of health can help us better tailor solutions to the health disparities that we face. Specific, disaggregated data on healthcare access, individual economic resources, exposure to negative environmental factors, language barriers, and race and ethnicity would help allow us to understand the issues that we are up against and enact more precise solutions to those problems. That's why I'm so happy that AAMC decided to host today's briefing and has been such a champion of this issue. Once again, thank you all for being here today. Hello.
Thank you so much, Congresswoman Chu, for highlighting the importance of data disaggregation within both racial and ethnic minority populations. And I like how you noted that it's really just the tip of the iceberg to addressing social determinants of health, but it's such a critical starting point. I'd also like to thank Congresswoman Chu's staff, Ellen Hamilton, Anissa Asim, Janet Christensen, and the rest of her staff for helping to put together this important video. As the Congresswoman noted, and I think we all know, that the pandemic really laid the health inequities that occurred through the pandemic, but importantly, that those health equities were already in existence, but it's just that the pandemic really brought them to the forefront. It's also mobilized calls to focus on further upstream opportunities to improve health. Emerging from this crisis, the AAMC has been united more than ever on our approach and thought leadership and developing evidence to support health and social justice, largely through our Center for Health Justice. In 2019, under the leadership of our then new president and CEO, Dr. David Skorton, the AAMC began developing a new strategic plan, which led to the establishment of the Center for Health Justice. With that, I'm so pleased and honored to turn now this presentation and briefing over to our moderator, the founding director of the AAMC Center for Health Justice, Dr. Philip Alberti. Dr. Alberti?
Thank you, Karen, and thanks again to Congresswoman Chu for your leadership on this important issue. I'll have a bit more to say about the AAMC Center for Health Justice towards the end of our conversation, but to frame the discussion, I did want to point out the three kind of guiding principles of our center. The first is that the solutions to health inequities can be found in the wisdom of our communities, not in our labs and not in our doctor's offices. Community engagement is key. The second is that a community's health requires both the presence of and the coordination of the vital conditions for health that you see represented on the graphic created by Community Commons. That includes humane housing, meaningful work, basic needs for health and safety like access to medical care, yes, but also nutritious food, clean air, and freedom from racism and bigotry. Community health is a multi-sector endeavor. And third, that the right level of intervention is one that shifts the context for entire populations towards equity and justice, that puts all communities at the same starting line for health. And that requires policy change at federal, state, local, and organizational levels. And today's conversation about data for health equity resonates across all three of these guiding ideas. If we agree that what we need are data, national, standardized, comprehensive demographic and social data in order to identify inequities, develop those hyper-local solutions, and track our progress and success, we need to first co-develop that data collection system with communities, not just to identify the right data elements, but to understand the right way to ask the questions, the best way to report out those data so that communities can actually use the data for their own health. Second, we need to ensure that all sectors can use the data seamlessly, that variables are defined in the same way, that they can share data in a way that protects individual privacy, of course, and also facilitates collaboration and evaluation. And third, we have to use the data to develop and make the case for policies that will shift that context, that will ensure that equal starting line for health for all communities. And our four experts that are with us here today are going to help us think through some of the opportunities and challenges to get us to that kind of national data collection system. So I'll first turn this virtual stage over to Mr. Daniel Dawes, the director of the Satcher Health Leadership Institute at Morehouse School of Medicine and a professor of health law, policy, and management. His research focuses on the drivers of health inequities among under-resourced, vulnerable, and marginalized communities, and he is a pioneer of a new approach to examining inequities, the political determinants of health. Daniel, over to you.
All right, well, good morning, everyone, and thank you so much, Philip, for that very kind introduction. I am so pleased to join you all today and join this esteemed panel. And I do want to thank the AAMC Center for Health Justice for hosting this important discussion. So I want you to take, next slide, please. I'd like you to take a moment to just let these numbers wash over you. These facts only begin to scratch the surface of the disproportionate carnage this virus is inflicting on our most marginalized people in this country. I could go on and on about these dark statistics. Well, actually, I probably couldn't, right? Because eventually I run into a wall of available data that highlights this problem. Sadly, the old adage of if there is no data, then there is no problem apparently remains true in 2021. Next slide, please. We as a country have experienced pandemics and crises before. And due to the innate resilience of the people living in our country, we've always weathered these storms and emerged stronger on the other side. However, what is interesting is that we've never achieved an equitable response to a pandemic specifically. And I believe that this is our opportunity to do so. But to actually achieve an equitable response, we have to know what inequities exist and persist across the country. You see, when it comes to reporting COVID-19 case data, gaps are prominent, most notable for race and ethnic groups, physical and mental health status, and sex categories. To date, we know that there are no required or standardized race and ethnicity categories for data collection across state and local jurisdictions. And when we consider data completeness, we see an alarming percentage of unknown data. In fact, the CDC's data set only has 65% of race and ethnicity reported. So what does this mean for health equity? Next slide, please. Many, of course, believe that if there is no data, there is no problem. But at the Satcher Health Leadership Institute, we know that is certainly not true, which is why we set out to do something about it with our partners. Creating a data platform to track health inequities as close to real time with COVID, the comorbidities, and beyond. While there are a number of trackers out there right now that are looking at COVID data specifically and doing so very well, I might add, the tracker that we've designed takes a more expansive look at health equity specifically to truly inform people of the problem and attempt to fill in the data gaps that have long plagued us. This health equity tracker is a public-facing data platform usable by any and all that exists to, of course, track chronic conditions, help folks understand the health equity impact on mental and behavioral health outcomes, examine select social and political determinants of health, and of course, provide technical assistance and policy recommendations to jurisdictions across the country. What is most important is that our tracker will live beyond this COVID-19 pandemic and continue to facilitate the conversation around health inequities and the data highlighting such. Next slide, please. At a more macro level, this health equity tracker shows the reporting disparities and inconsistencies we have across all states. To date, 37.5% of cases nationally were reported with unknown race and ethnicity, and a total of 6 states still have not reported any COVID-19 related data to the CDC. This brings so much attention to the importance of not only having the data for analysis, but making sure data collection is consistent. In the building out of our health equity tracker, it became readily apparent very early on that the lack of a federal standard for collecting racial and ethnic data was going to be a large part of the story. The reality is that if we cannot statistically point to the harm being endured by a given segment of the population, then we continue to facilitate with ease the adage of no data, no problem, to those who hold the power to drive the changes that we so desperately need. Next slide, please. So before I close, I do want to take a moment to push back on a common refrain I've heard and read as of late, and that is a desire to return to normalcy. But to put it bluntly, there absolutely cannot be any return to normalcy. Normalcy failed us before, and it will fail us again. Normalcy before COVID-19 left marginalized communities without the resources they needed to survive and thrive, and without the data to tell their stories. We absolutely cannot ignore the tough lessons we've learned by attempting to return to a pre-COVID-19 mindset. You see, the data landscape before COVID-19 was just as dire as it is today, which means we have an opportunity to act right now. Normalcy is not equity, and equity should be our only option moving forward. Thank you all so very much. Next slide, please. To learn more about these efforts or to join our efforts, I urge you to contact us at the Satcher Health Leadership Institute. Thank you so much.
Thank you, Daniel. No return to normalcy indeed. Thank you for that reminder. It's clear that efforts like the tracker and efforts like it are hamstrung by the spotty nature of our public health data. But it's not just public health and medicine that need this kind of information. All of our partners in the health ecosystem have similar needs. And so to add a perspective from the housing sector, I am honored to introduce Ms. Michel Perez, who serves as the Assistant Deputy Secretary of the U.S. Department of Housing and Urban Development's Office of Field Policy and Management. In this role, she oversees the department's regional and field offices as they deliver on HUD's mission to create strong, sustainable, inclusive communities and quality, affordable homes for all. Michel, thank you for being here.
Thank you for the invitation to participate on this panel of such distinguished experts. And thank you, Philip, for your generous introduction. Housing is a social determinant of health, full stop. I'm here to discuss the role that the federal government serves with respect to health equity and housing equity based on lessons learned in the last 5 months as part of our COVID-19 response. On day one, President Biden issued the executive order advancing racial equity and support for underserved communities, which defines equity in very specific terms and calls out marginalized groups by name, which is both meaningful and purposeful. HUD Secretary Marcia Fudge has stated that HUD is taking a critical step to affirm that a child's future should never be limited by the zip code into which they are born. Her statement is notable because how we got here is a culmination of US government actions formally dating back to 1934 that created and perpetuated residential segregation, which have had profound individual and generational impacts and have resulted in compounding and intersectional levels of harm. It is for this reason that President Biden identified the ongoing legacies of racism and specifically called for HUD to address and redress the federal government's history of discriminatory housing practices and policies. And he called for us specifically to fully implement the 1968 Fair Housing Act's provision to affirmatively further fair housing. That interim rule goes into effect on July 31st, exactly 10 days from now. Why that's so significant is because also on that same date, we are preparing to address even greater housing instability as both the CDC's eviction moratorium and HUD's foreclosure moratorium for FHA loans are being sunsetted. Just yesterday, Secretary Fudge testified in front of the House Financial Services Committee and discussed the inextricable link between COVID-19 and its impact on health and housing. What we know is that HUD-assisted households and communities have a higher prevalence of risk factors that place them at increased risk of COVID-19 transmission, illness, and mortality. A large proportion of HUD beneficiaries are people of color, are age 65 or older, have disabilities, and have underlying health conditions. For example, the proportion of HUD tenants in high-risk age groups exceeds the national average by more than double for individuals 62 and older and 85 and older. Relative to adults nationally, HUD-assisted tenants are at a higher risk of dying from COVID-19 than the general population because they have a greater proportion of higher rates of cardiovascular disease, chronic obstructive pulmonary disease, hypertension, diabetes, and severe obesity. Moreover, HUD customers live in high-density housing or congregate settings, including emergency shelters, transitional housing, not even to speak of the unsheltered population. And as a result, they have unreliable, if any, internet access or transportation, which both exacerbate their risk and limit their options to receiving COVID vaccines. On May 5th, and in response to President Biden's executive order on ensuring an equitable pandemic response and recovery, both Secretary Fudge and the U.S. Health and Human Services Secretary Javier Becerra announced a joint agency effort to support disproportionately affected communities, and specifically including HUD-assisted households and people experiencing homelessness. As Assistant Deputy Secretary, I oversee HUD's regional and field offices, and I'm leading this partnership with HRSA on the ground. Our collaboration married housing providers with federally qualified health centers to bring COVID vaccines directly to the communities with low access, low confidence, or low ease of vaccination. We use GIS mapping tools to pinpoint the proximity of HUD properties with these health centers. We defined priority communities, those that were, for example, more than 8 miles from a federally qualified health center, or who had at least 20% HUD-assisted residents per zip code. We published the GIS maps on our website, and today there are 274 priority communities in all 50 states, including the District of Columbia and Puerto Rico. Since May, we have partnered to conduct 465 vaccination clinics where the people are, at HUD-assisted properties, community-based organizations, and at SQHCs nationwide. But what we've learned in so doing is the inevitable conflict in data and taxonomy. How are we measuring effectiveness of our efforts? How are we utilizing hyper-local targeting to identify those discrete pockets of individuals who have yet to make the decision to get vaccinated? And what systems are available to help us determine coverage? HRSA tracks special populations receiving doses, and as of July 2nd, that was 5.5 million, and of those, 3% were identified as those experiencing homelessness, and 4% were residents of public housing, according to HRSA. You see, the Public Health Service Act has a different and far more expansive definition of public housing resident than HUD. And yet we can't definitively state that that number is accurate. For example, would an individual who lives in a HUD-assisted, privately owned and operated multifamily property, also known as project-based Section 8, if they lived in close proximity to a housing authority, would they consider themselves a housing authority resident? Likely not. Nonetheless, for all 465 clinics, we know that a third of the vaccine administration was provided by FQHC staff. But what about all of the other partnerships that HUD has established with providers other than HRSA, i.e. local or state health departments, FEMA, National Guard mobile units, or even private pharmacies? In conclusion, the level of effort can and will be sustained, it must, throughout the duration of this pandemic, especially as we monitor the effects of the Delta variant on such vulnerable populations. But what we also know is that the data is not commonly defined, is not easily available, and given the practical limitations of data use agreements between federal, state, and local actors, we've got lots more collaboration and partnership to engage in with the folks on this panel, in this virtual room, and beyond. Thank you for your time.
Thank you, Ms. Perez. Cross-sector coordination and alignment of definition are so important, especially for HUD-assisted households where so many of the social determinants of health intersect. And when you have the right data and can deploy it in a coordinated, aligned, and multi-sector way, the benefits multiply, as we'll now hear about from our next speaker, Dr. Rhonda Randall, the Chief Medical Officer of United Healthcare Employer and Individual, the nation's largest business serving the health coverage and well-being needs of the United States. Dr. Randall, the floor is yours. And one quick note before I turn it over to Dr. Randall, please start submitting your questions for our speakers in the Q&A panel that you'll see on your Zoom screen. Dr. Randall, thank you.
Thank you, Philip. Pleasure to be with all of you today. Well, stemming from United Health Group's longstanding belief that all individuals should have access to high quality, affordable healthcare that meets their unique healthcare needs, United Health Group is deeply committed to addressing health disparities and advancing health equity. For more than 2 decades, United Health Group has led efforts to identify, monitor, and address health disparities in collaboration with community organizations and national partners. Using data and advanced analytics, we're able to apply clinical insights to rapidly identify local health trends and gaps in care, and then partner with local communities to improve the health for our members and to help optimize limited state resources. For example, the United Health Foundation released its inaugural America's Health Rankings Disparities Report on June 29th this year. Building on 31 years of data from America's Health Rankings, this new report provides objective data across 30 measures of health and documents health disparities for the nation, for all 50 states, as well as the District of Columbia, by race and ethnicity, gender, geography, and educational attainment. The report can be found at americashealthrankings.org, and it includes pre-pandemic data. We wanted to provide a clear picture of disparities before the impact of COVID-19. Some key national findings from that report include females reporting a 70% higher rate of depression than males in the period of measurement between 2017 and 2019. Maternal mortality rates increased from the period measurement of 2005 to 2009, and then the period of measurement between 2015 and 2019, with Black and American Indian and Alaska Native mothers facing the highest rates of maternal mortality. We also saw disparities in food insecurity, most significant by levels of education, with households that are headed by adults who have less than a high school education having a 6 times higher rate of food insecurity than households headed by college graduates. At the same time, both groups experienced worsening rates of food insecurity even before the pandemic. Next slide, please. I want to share with you some of the community investments that United Healthcare has made in housing nationwide. Those community partnerships are designed to help vulnerable populations manage specific medical conditions. United Healthcare has collaborated with community partners to help provide housing for populations suffering from diabetes and childhood asthma. Through our Community Catalyst initiative, United Healthcare expanded our long-term collaboration with the Council of Large Public Housing Authorities through joint engagement with federally qualified health centers and community-based organizations to close gaps in care and address health equity challenges. United Healthcare works with community partners to analyze claims, healthcare utilization, and local data to identify communities with large healthcare disparities and challenges. UHC and our partners developed customized intervention for those communities, including those experiencing food insecurity and residents of public assisted housing who are often difficult to reach. Next slide. I want to transition and show you a couple examples of some of our Medicare Advantage members, Sarah, Bob, and Tom. Our clinicians provide personalized interventions to help seniors manage complex medical conditions. United Healthcare offers a program called Navigate for Me, which is a personalized care program specifically for our Medicare Advantage members, and really speaks to our value proposition, how we can improve outcomes for our most vulnerable populations, not only Medicare Advantage, but the similar outcomes that we shared with our Medicaid enrollees. Our Medicare Advantage members have some of the most challenging healthcare conditions. They're likely to have 4 or more chronic conditions. And the navigators, the clinical navigators, are able to provide a single point of care for all of their healthcare events. In fact, we know that more than 2 million of UnitedHealthcare's Medicare Advantage members experience complex health conditions every year. And we track data on more than 10,000 data elements every day to identify these members. We then use that information to target initiatives, including not only physical and behavioral health, but important social determinants of health, essential to having an impact on improving health outcomes. Next slide, please. And here's the impact when we do that millions of times over. 427,000 members served by this program, and the results include significant decreases in hospitalizations and emergency room visits. Importantly, all of that comes along with very high satisfaction among the program's participants. That concludes my remarks. Thank you.
Thank you, Dr. Randall, for the work that you are leading at UnitedHealthcare. And thanks to our next speaker, Dr. Gail Christopher, for her leadership both as the Executive Director of the National Collaborative for Health Equity and the Director of the National Commission to transform the public health data systems at the Robert Woods Johnson Foundation. She is an award-winning social change agent with expertise in the social determinants of health and well-being and related public policies. Dr. Christopher.
Thank you so much. And I so appreciate the creativity of AMC in organizing this briefing. It is absolutely essential. Let me say a little bit about the National Collaborative that I lead. We focus on health equity and have for several decades now. We believe that equity is the opportunity to be healthy. When we talk about health equity, we really need to design a society that provides the opportunity for all people to experience health, not only the absence of disease, but to experience well-being. We do this in partnership with organizations across the country, with local communities, and we were so pleased to have been invited to work with the Robert Wood Johnson Foundation in its creation of the National Commission to transform public health data systems. I'm going to share a little bit about that commission's work and invite you to stay tuned for our full release of our report in the fall. Next slide, please. The National Commission was charged with reimagining. You know, we have to measure, but we also have to have a vision for a future that no longer is defined by the legacy of our past that devalued some people based on their countries of origin or their physical characteristics. We have to imagine a future infrastructure in this society that values all people equally. And we believe our public health data systems infrastructure is critically important to designing that new future. And so the commission members have been charged with reimagining our data systems, modernizing them, figuring out how we work across sectors so we can optimize not only the opportunity that the pandemic presented, but also the opportunity that our innovations in data collection and data analytics, the opportunities that are presented by the progress in the private sector as well as the public sector. So this commission has come together to bring that hope and that energy into reimagining the actual infrastructure of a new public health data system. Next slide, please. Could I have the next slide, please? The commission is nonpartisan in nature. We recognize that the inequities that were revealed by the pandemic as everyone has said so far this morning, certainly predated the pandemic. They predated the 20th century. The inequities are grounded in the actual, I would say, genesis of our country. The inequities date back to our belief in a hierarchy of human value and our inability to create conditions that allow an optimal state of well-being and development for all communities. The commission is, as I said, nonpartisan. It's comprised of a diverse group of experts and leaders who represent multiple sectors, who represent multiple perspectives and levels of expertise, and who have been in their careers visionaries for this type of work to achieve health equity and to achieve racial equity. Next slide. The commission is certainly independent in nature. As I was saying before, the inequities that have been revealed by COVID-19 at the same time that our country has found the courage to acknowledge that it is time to reckon with our legacy of racial hierarchy. All of these things will fuel and are fueling the deliberations of the commission to help us come up with, I would say, a radically imagined new way of approaching data collection, data dissemination, and data sharing. And I really want to emphasize sharing. We have to figure out how do we work across our sectors so that we are nimble and we're able to be responsive in the moment, not only to the crises that are identified as healthcare crises and health crises, but to the crises that are really found in the broader context of social determinants. Your speakers this morning have shown such hope and such promise. And that brings me to the issue that I want to just remind us about. We do have a HOPE initiative at the National Collaborative for Health Equity. You know, we've been identifying health disparities and inequities for many, many decades now. And we've put together a platform that focuses as much on the future. It focuses on what states and localities need to do specifically to bring about greater equity. We have set goals for health equity, and we identify specific domains in which states can work and invest resources to move us toward greater health equity. And those are the domains of the social determinants of health, of which I believe access to medical care is one. So there can be no question that we are at a time in our country where we can move forward faster. There is an African proverb that says to stumble is not to fall, but to move forward faster. And we will have to move forward faster by having not only the data, but the data infrastructure. We cannot fix it if we don't measure it. And so we need to measure all of our progress in all of these domains. We also need to measure our progress in overcoming the legacy of racism in this country. So I want to thank you all for inviting me to be part of this panel this morning. And I want to applaud all the speakers that have said so much that demonstrates the potential for us to overcome this burden that we have now and to create a much better future, a much more equitable future for all of our country. Thank you.
Thank you to all of our speakers for your perspectives and your commitment to health equity. It's clear that tools like the Health Equity Tracker and others that aim to harness the power of data to promote equity, tools that would be useful for so many sectors representing those vital conditions for health, are held back by the lack of data. And so I'm eager to get into the Q&A and this conversation about how we can take the foundation that Dr. Christopher and the Commission are building, the lessons learned from United Healthcare and others, and go further and go deeper. So I encourage you to please continue, audience members, to enter your questions into the Q&A panel. And I'll start us off with one before we get into your questions. The AAMC Center for Health Justice, our first deliverable was our principles of trustworthiness, 10 guiding statements and accompanying actions that organizations of all kinds can follow to demonstrate that they are worthy of a community's trust. You can see the first three on your screen and a link to the others in the rest of the toolkit. Trust is foundational to community engagement and partnerships. And community partnerships, as we've heard, are crucial for health equity work, including data for health equity work. If folks don't trust you, they are not going to share their data with you, particularly sensitive data like social risks. And so that's one fundamental barrier we face. And Michele, I'll start with you because you briefly mentioned trust in your remarks. What's your advice? How can we ensure that if we build it, if we build this national socio-demographic data collection capacity, how do we know that if we build it, the data will come? What's the urgent trust building work right now? How do we engage communities in the process, even the federal processes now underway?
Thanks for that question, Philip. I think, it's so remarkable that the things we know to be true remain true. And it's on us to actually influence and move that understanding. For HUD and HHS to partner, two government agencies to support communities that are particularly vulnerable and in need of assistance to fight a global pandemic, the fact that we've sort of partnered together to say we have a priority to do the jobs that we are entrusted to do doesn't mean that by definition the community trusts us to be able to do it. We alone, the government, cannot, we know for a fact, convince individuals, persuade individuals, or partner with individuals who don't have a long or steady history of trust with the government. We have broken ourselves into component pieces, and we don't understand that when a community interacts with their government, they're interacting with from a holistic perspective, whether as an individual or as a community. So I would tell you that the key factor that we've learned is this sort of iterative cycle of engagement, of planning, of connection, which has resulted in these vaccination efforts. It's not our focus, but rather our attention to the work that's already happening on the ground by community advocates, faith-based groups, by those trusted messengers that we've heard so much about. The truth of the matter is, until we make those connections, the reality is that housing authorities and continuums of care who work with those that are experiencing homelessness don't necessarily have ready-made relationships, don't necessarily have entry points that are coordinated. That's the role and the space for us in government to influence and to persuade individuals who are running those organizations, but more importantly than that, not just as a pass-through agency, the customers of our customers are also our customers, and that they need to understand that if and when necessary, they can call their federal government for support, and they can trust that they'll be heard, they'll be recognized, their history with that government will be acknowledged, and that we will demonstrate an honor and a commitment to the dignity and self-determination that they have to help them advance their priorities, to be very client-focused and centered in our understanding of what the community needs and wants.
Thank you, Michele. To trust is one fundamental barrier, but there are others, of course. And so, Daniel, I'll turn to you next. We've had many conversations about the need for data transformation and the barrier of missing data. And so here's one question for you. Could you please highlight some of the challenges related to the data gaps that you underscored and the impact they've had on the transformation of data collection, the transformation of data reporting that you and others have encountered?
Yeah, absolutely. So I think, one of the most persistent challenges that we've encountered has been in regard to a lack of standardization. And I know I spoke about it very briefly. Right now, the most up-to-date data for COVID cases, hospitalizations, deaths, and vaccines are scattered across state and local public health departments, websites, and they are using different standards and categories for reporting on race and ethnicity. And so, that is a problem that many of the COVID trackers, whether the New York Times or the Johns Hopkins or others, encountered and they try to address with volunteer human power. And it's the reason why, the health equity tracker that we were working on leans so heavily on technology to automate as much of that data collection and aggregation as possible. But beyond this, what we've also seen is that many of the agencies do not reliably collect race and ethnicity data, while some of the others that do collect it, they actually fail to report it, right? Which means that the data that is not getting into the hands of those of us who so desperately need it to tell the stories and fight for the communities that are unrepresented because of that lack of data. And then, even when we look at the gold standard of data collection, the CDC some of these data sets fall short. So, for instance, the CDC's restricted data set that we at SHLI asked for and were granted permission to access earlier this year. This data set has additional fields to help paint a fuller picture, yet the additional fields that include whether the person died or was hospitalized are only known for fewer than 50% of the cases. So, that presents a host of problems for us. But I'll just stop there because there are a host of other things. I mean, I'll add one more thing actually, if you don't mind. And it's this idea of, even when we move beyond COVID specific data, there is a glaring and undeniable reality that there is simply an inadequate amount of data that analyzes and highlights the upstream factors that perpetuate many of the isms, as Dr. Christopher was mentioning, in our society. And I think it's important that we're able to quantify the social and political determinants of health and their impact on health outcomes. That would work wonders, as we know, for telling the story of health inequities in our country.
That's such an important point, Daniel, that it's disaggregated race, ethnicity, but it's also individual social risks and community social determinants to really understand where and how best to intervene. So here's a question for all the panelists. It's actually come in a couple of different ways from our audience members. Can you speak to what specific investments or specific pieces of legislation are needed to build the modern day public health infrastructure that Dr. Christopher mentioned, the commission is working towards, as it relates to training, as it relates to workforce, as it relates to health equity movement across the board? So maybe Dr. Randall, will start with you on thinking about specific investments in legislation to push the work forward.
Sure, and I'd particularly like to address the one related to workforce. This is something that United Health Group and the United Health Foundation have had a longstanding interest in since 2007. The United Health Foundation has recognized that a successful pipeline of healthcare professionals for growing diversity in the healthcare workforce is important, and we've had partnerships with leading nonprofit and civic organizations. So this really ties back to the piece around partnership. And we've used that Diverse Scholars Initiative to increase the number of primary care providers who are ready to deliver that local, personalized, culturally competent care, predominantly in underserved communities. So since 2007, we have provided more than 25 million in funding and nearly 3,000 scholarships. That initiative has supported 234 undergrad and graduate students across 36 states currently. And they range from those who seek to be nurses, primary care physicians, current residents, particularly those specializing in internal medicine and other primary care specialties. So with the most recent class, we see a nice example of undergraduates, doctoral students, and graduates. So that investment, that longstanding investment in the future of our healthcare workforce has been an important tenet for us, along with the partnerships and nonprofit and civic organizations.
Thank you for that. Dr. Christopher, do you have anything to add in terms of the infrastructure as your commission's considering the work? Are there specific immediate investments, immediate pieces of legislation that we should be drafting or supporting?
We should certainly be investing in our public health system, strengthening our capacity at the local and state levels across the country. We also must invest in measuring our progress. We must invest in measuring our inequities and our disparities, but we have yet to design an approach to actually holding ourselves accountable for tangible progress in well-being, progress in terms of the broader context of social determinants of health and well-being. So our creative investments in this moment, in this opportunity moment, they have to deal with, are we tracking how much progress we are making in moving toward a society that is not divided by these antiquated ideas of difference and hierarchy? How are we measuring our progress toward becoming a society that has reckoned with the truth of its past and is committed to actualizing its aspirational concepts of equality and equity? But if we don't believe that that's a priority, we won't measure it. And so we have to really think about a new way of imagining and reimagining what our country must do.
And Philip, if I could also add to that, is that okay?
Of course.
Thank you. Okay, so I also think the federal government needs to invest in the deployment and financing and maintenance of a national public health data infrastructure. Because right now it's like we're flying a plane with 50 different instrument panels, right? And so is it any wonder then why we've been encountering the many problems around data during this crisis? So I argue that the CDC has the capability to address many of these challenges, but in order to do so, they should be provided the resources to assemble and publish comprehensive COVID outcomes and vaccine data, right? As you heard from the Assistant Secretary Perez, working with them to also invest in the other agencies so they can come together and collaborate in the formation of that national public health data infrastructure. And then, I think this could come in the form of examining also policy or regulatory options to compel the collection and reporting of these critical factors that we've been talking about from the local agency level. I would also say that we need a registry in primary care practices, right? To identify and track COVID patients with detailed demographic, social, and medical history, because public health has no real access to a lot of these data sources. So we need to do a much better job in that vein as well.
Thank you for that, Daniel. And I will note, there are specific pieces of legislation like the Social Determinants Accelerator Act that will encourage data sharing and establish programs that lead to an interagency approach. There are also, significant or specific investments in pieces of legislation that might facilitate some of this work. Daniel, you were talking about kind of a national public health infrastructure that would almost scoop up much of the work of the tracker and other tools. I wonder if other folks on the panel have any idea of how we achieve that kind of alignment and consensus to get us to a place where there is a standardized set of variables and collection strategies that would obviate the need for kind of homegrown individual solutions.
I would just say that, and this panel is a step in that direction, and it will be part of our recommendations moving forward. But we really have to create a new narrative about the primacy of public health, not only public health data, but public health as an institution, public health as central to the viability of our democracy. And we have to galvanize the public's trust, to use your term again, trust in public health as being core to our well-being. And so part of this work is to create a leadership, a broad-based leadership call for reinvestment in both the public health system as a whole and understanding that data is at the heart of that system. So we really do have to put some energy into creating a new narrative about public health and not see it as something that we only call upon in the case of an emergency. Most of the really important work that public health does, nobody hears about because there are no problems. So we have to revisit, how are we talking about public health? How are we engaging multiple sectors in the conversation? And what is the leadership to put the issue of public health data right at the center, at the heart of our recovery?
And I'd like to add to that, because I think, Dr. Christopher, you raise a great point. How we approach this means in spaces that are not accustomed to commonly having conversations about public health, recognizing that it is so integrated, that it is such a part of the fabric of the work that we do on a day-to-day basis, that we're no longer limited in simply isolating it to those agencies who do that work over there. And that, I think, is something that is common, not just to the topic at hand, but I think broadly speaking with equity writ large, that this is something that we apply a lens of equity in all of the work that we do as we evaluate the policy, as we consider the ramifications, and even before that, to the workforce considerations, how we look at ensuring that our workforces in each of these respective organizations are representative of the populations that we serve and who feel safe to be able to have a conversation, an honest and candid conversation about how we talk about equity, how we uplift this work, and how it's encouraged and supported throughout the workforce and commonly understood, not just by the people who are promulgating the work, but all the way down the line, so that there's a reflection in the execution of the work with what its intention was originally at the start. That disconnect is work that we have and must continue to engage in.
And that's foundational to trust and trustworthiness, like we were talking about at the outset of our conversation. So we only have a few minutes left, and so I want to ask one final question, maybe rapid responses. The question is this: it seems like there are so many missing segments, both data elements, sectors at the table. What can we actually expect to achieve realistically in this front in the next 20 years? What would success look like to each of you? We'll start with Daniela and go down the order of
Oh my goodness, you would start with me, right? Didn't even give me a second to think about it. But, what success looks like to me would be, a society where equity and inclusion are just foundational, right? It is a given. It's not something that we necessarily have to think about. I would love to see that in the next 20 years.
Michelle.
I'll start with where we know is unconscionable for a country such as ours, which is the fact that there are so many individuals who are living unhoused in this country today. That is something that we know we can, in fact, solve. It requires a commitment and a willingness to understand how issues such as mental health, such as substance abuse disorder, and other corresponding factors with housing, and the fact that where housing is not in existence, how we then approach that crisis, and how we use housing first as a model to approach that crisis. That, I think, is an environment that I think is success is within our reach. We can identify it. We know who all the actors are. We know where all the systems are, and is a first step, I think, to demonstrate something that as a moral obligation of our nation, we can make a meaningful impact.
Thank you for that. And Dr. Randall, same question. What's success for you?
I think it is taking the successes that we've had at a local level and seeing them happen at scale. So, all of our organizations have bright spots that we can point to where we have identified data and trends and used that advanced analytics, worked with partnerships, focused on specific populations, and made measurable improvements in health and outcomes. And so doing that at a level of scale, I think, is the next step in defining success.
And again, that requires these data elements. Dr. Christopher, please bring us home, wrap us up.
Okay. I think our success will be having moved beyond denial of our disadvantage in terms of a global perspective. We do not do well as a nation in terms of health. And at the heart of that is our lack of ability to invest in our social infrastructure that is necessary to assure opportunity for all people. And so if we move past denial of that, and we have galvanized the intention and the determination to create opportunities for health for all people, recognizing that we have to face the truth of our divided past so that we don't perpetuate that same division into the future. But I think we can, and I think we will do it. The viability of this experiment in democracy depends upon us doing it and doing it together.
You're here. Thank you for that. So this ends our time together today. Thank you all to the panelists for sharing your wisdom and your calls for action. If you'd like to stay connected to the AAMC and the Center for Health Justice in the run-up to our September 21st launch, here are 2 quick ways to do so. You can sign up for our monthly updates, funding announcements, tools, resources, conferences, etc. You can also join our Collaborative for Health Equity, which is open to all and is really pitched at local community action, galvanizing that multi-sector partnership on the ground to spark those local successes. And one last thank you. Here are a bunch of different ways to get in touch with myself. If folks have congressional inquiries, my colleague Matthew Schick, and some information about the center's website, etc. So again, thank you for spending the hour with us, and we look forward to partnering with you in this important work for Data for Health Equity.